how do we talk to him now when he has this, and like this awkwardness of like people want to say things, or they're afraid to say something wrong or offend me, so sometimes they don't say anything at all.
Hello, this is On the Subject of Cancer, a podcast brought to you by New England Cancer Specialists. My name is Jessica Fidalgo, your host. Today, our guests are NECS President and oncologist Dr. Devon Evans and advocate and colorectal cancer survivor Trevor Maxwell. This is a two-part episode. Be sure to come back to listen to part 2. While the subject is cancer, this is mostly a podcast about people. Every episode, we sit down with someone who has lived through or is a specialist in the treatment of cancer, and we ask them about their experiences, their knowledge, and anything they're willing to share. If you're listening as someone touched by cancer, whether that's personally or through someone you love, you're not alone, and we're glad you're here. Let's get into today's conversation with Dr. Devon Evans and Trevor Maxwell. Welcome, gentlemen. Thank you for agreeing to be early podcast guinea pigs for me. This is definitely my first 3-person format episode, so it's very exciting.
Happy to be here.
I believe I read somewhere, Trevor, we've met a couple times now, but haven't really ever had a chance to talk a ton. You have a journalism background.
Yes.
And you also have your own podcast.
I do. Love podcasting. It's great to see New England Cancer moving, into this space. Yeah. Is this the first time they've done a podcast?
This is our first time we've ventured into a podcast territory. Yeah, I'm excited.
Yeah, so my professional training was as a journalist. That's what I went to college for, and I spent about 15 years working for daily newspapers. The last daily newspaper I worked for was actually right here at the Portland Press-Herald. Between, it was a long time ago. I think I left the Press-Herald right around 2011. What a great experience. A great training ground for anything in life, I found. Really enjoyed my journalism years. And that's why I started my podcast, was because I missed interviewing people. Mm-hmm. And I missed finding out about their experiences and really diving into it. So I do the Man Up to Cancer podcast, where my guests are other cancer patients, caregivers, providers, people in that world to talk about their lives.
Okay, we should definitely get into that a little more later, and we want to make sure we have a link in the show notes to the Man Up to Cancer podcast, which is awesome. Dr. Evans, you do not have a podcast, to my knowledge.
I do not. No, I'm new to the podcast world.
That's all right. I feel very honored to be your inaugural podcast experience. But you are a physician. You're an oncologist. You've been with New England Cancer how long?
Over 18 years now.
That's
shocking to say out loud. Yeah, it's a long time.
And you're the president of our organization now.
Newly since the beginning of January.
Newly inaugurated.
Settling into the role.
That's
correct.
Great. That's great. How did you, tell me about becoming a doctor. Did you always want to be a doctor when you were a kid?
I don't think necessarily when I was a kid I would rate that origin to college, just taking a lot of science classes and looking forward to what was next. I don't have any physicians in the family.
You don't?
I don't have any clear family role models in this regard. So it was a bit of a leap of faith at that moment.
And it seems to have worked out.
And then the larger question, as it turns out, is, where in medicine do you want to be? Mm-hmm. And I was lucky enough in medical school to get to spend time in an outpatient clinic with an oncologist. Typically, residencies focus on inpatient medicine, and the oncologic side of that is not necessarily a happy place. Mm-hmm. But I was lucky enough to see longitudinally the care of cancer patients in an outpatient setting at that early moment, and see the relationships you could develop with people over time. And that was really appealing.
That's very cool. So if it hadn't been oncology, do you think there was a second kind of specialty maybe waiting in the wings, or was it just full steam ahead?
Yeah, I think if anything, the second piece was actually at a lovely pediatric cardiology experience. And I love the physiology of that field, but the idea of working with sick kids was never going to fit me entirely.
Yeah, that's a tough one for sure. I have a question actually on that same topic here that I want to ask you later after we get into it a little bit. But the primary reason that you are both here guests together is because you are doctor and patient. Trevor has been your patient for, I'm thinking, 8 years.
Almost half of his career.
Amazing to think about.
It's a very, very long time to have a provider and patient relationship. Is he one of your longest standing patients?
Believe it or not, no, is the answer to that. I joined the practice in 2007, and I still see patients from that era, which is amazing.
That is amazing, and
Yeah.
definitely a testament to, the treatment that they're getting. So let's get into talking about Trevor's diagnosis kind of more specifically. Trevor, can you walk us through, I know you've talked about this in many forums for us and in many other places, but just to give a high level, walk us through your diagnosis and kind of what the early symptoms were for you.
Well, I got to get out the giant whiteboard, and then we'll just walk through it step by step here. It's going to take 3 or 4 hours. This will be like a Joe Rogan episode. So my diagnosis, I was in the winter of 2017 going into 2018. I was 41 years, just turning 41 years old. Really in the middle of my life. My wife and I were living in Cape Elizabeth, Maine, raising our 2 daughters. Sage was 12 and Elsie was 10 at the time. And my wife was a teacher in South Portland schools. And like I said, my background was in journalism. And then after journalism, I started my own communications consulting practice. And so we just had super busy lives in the middle of our, in the prime of our lives, really. And then that winter, I started to experience some really significant fatigue. And it just kept building and building, like the type of fatigue that started out feeling like I'm just in the middle of my life. This is kind of maybe moving towards that midlife fatigue point. The kids are busy, we're busy. Thought it was normal. And then it just kept progressing to the point where I remember walking up a set of stairs and my heart would just be pounding. And my resting heart rate all my life was really low, like around like 50. And that winter, even when I was resting, it would be up around 65 or 70. So, but like a lot of guys, we don't have a lot of touches with our medical providers. We had a primary care physician and a great one, but I wasn't going in for annual physicals.
Sure.
I wasn't having any touch points, but finally, so like a lot of guys, I just kind of put it off. Like, you know what? I'm just tired. It'll get better. Well, it didn't get better. And so finally I reached out to our primary care physician. Shout out to Dr. Tara Pelletier, formerly of Intermed, who's amazing. And I said, this is going on. She said, this is probably nothing serious, but we should get some blood work. Had blood work, showed I was very anemic. So basically had very low red blood iron in my blood. And usually when that happens, she had asked me, are you bleeding? Have you had any bleeding events? Is there any reason why you would have low iron? And I said, no. And she said, we need to get you scheduled for a colonoscopy. Oftentimes, when there's no other signs, it means that there's blood loss somewhere in your gastrointestinal tract. So went in for blood work. And this is one of the days I'll always remember was when the blood work came back, Dr. Pelletier left a message on my phone that I didn't hear the call, but she said, you're very anemic. Don't do anything strenuous. Like, please call me this weekend, like anytime. And when you hear that from a PCP, that's usually not a good thing. Yeah. And I remember standing in my driveway and thinking like, man, I just hope this isn't anything serious. Well, she got me in for a colonoscopy like right away, like within a week. And even at the colonoscopy, the gastroenterologist looked at me, healthy, vibrant, 41-year-old, and said like, we're going to find something to explain this. I'm sure it's, we're going to find out what's going on. After the colonoscopy, I came out of the drug haze and the nurse said, you and your wife need to go see the doctor. Go into the room. They closed the door. And the doctor had a totally different countenance, like, the look on the face of that this is bad news. And he said, Trevor, you have about a 9 to 10 centimeter mass in your ascending colon. We took biopsies, but we're going to need to get you an urgent referral to a medical oncologist and a surgical oncologist because this is something that's a pretty urgent situation.
Okay. Sidebar, is that big with 9 millimeters? Is that size-wise?
It's larger than what we see for most colon tumors, although size doesn't really play much of a role in terms of how we think about it in terms of extent of disease. It's more about how deeply invasive the cancer it is, whether it's spread to other areas, lymph nodes, at other parts of the body,
Okay.
et cetera.
Okay, good. That's good to know.
Yeah. So all of this was completely a shock.
Sure.
And I just remember like he didn't say the word
Oh, he didn't use the word cancer.
And I looked at him and I said, are you saying I have cancer? And he said, until the pathology comes back from the biopsy, I can't tell you for sure, but yes, I'm 99% sure that you have colon cancer. And that was March 22nd, 2018. So as we record this here this month in March 2026, that was 8 years ago. And I've been in treatment or surgery most of those 8 years since that day,
Right.
that diagnosis.
Right. And it is actually the month of March is March Colorectal Cancer Awareness Month, which is the reason we're recording this month with Dr. Evans. And that is stunning. That must have just rocked your entire world. And your wife's sitting there with you. I'm sure you're thinking, what is she thinking? And
Yeah, we were just really speechless. I
Yeah.
mean, went back to the car and sat there and just the tears were coming down for both of us and we didn't really even know what to say. I mean, because our first thought, of course, when you're an adult, when you're in your 40s, like your first thought is your kids.
yeah.
How are we going to tell them this? And so your first thought is your children. How are we going to share this with them? And then the second thought is, how do I treat this? I didn't know anything about cancer or colorectal cancer. And I was young, relatively young. And so I was all of a sudden thrust into this whole new world of treatment and what to do. And that was where I learned about New England Cancer Specialists first, was like, what is the order here? What do we do?
Right. So did Dr. Pelletier refer you, or did you get online and start digging and find, Dr.
Well,
Evans?
back then in 2018, New England Cancer really was the practice in Southern Maine. It still is the preeminent practice in Southern Maine. So it was kind of a no-brainer. It was like, you're going to talk to them. But the choice really was for surgery. It was figuring out what hospital to go for surgery.
Okay. So that was the first step. So, Dr. Evans, you're one of the specialists in colorectal cancer for our practice. What other types of cancer besides colorectal cancer do you see patients for?
Many different things, primarily gastrointestinal cancers in general,
Okay.
and then thoracic malignancies as well. Just listening to Trevor speak, there's so many themes to hit on here that he alluded to in so many different directions. One, the experience of being young and having a cancer diagnosis, and that feeling of shock. How could this be happening to me? Two, after that first moment, and maybe this realization doesn't come till later. You can tell me, Trevor, but the idea that you have unwittingly found yourself in a different group within population, and I hear so often this theme of isolation at a very early time point. You were part of a normal population, and then suddenly you're stuck in cancer land.
Yeah.
And that initial response you get from friends and neighbors, the head crook to the side, oh, I'm so sorry kind of stuff, immediately separates you. And that's really hard, particularly when you're at such a young age and you weren't expecting it in the slightest.
Oh, that resonates totally with me. I mean, I didn't know anyone in my age group who had that diagnosis. And now that I know now that I have it, I know that there are thousands of us around the country. But in my community here in Maine, I didn't know anyone in my community who was that age. And I knew some younger people that had gone through cancers, but colorectal cancer, I didn't know anyone. I knew grandparents and folks in their 60s, 70s, 80s, but not at 41. And so it was very isolating. I'd walk into like the IGA in Cape Elizabeth and I could feel like people kind of, all of a sudden you're in this separate group of people, like, oh, there's Trevor. You could see, like, what do we say to him?
Right.
How do we talk to him now when he has this? And like this awkwardness of like people want to say things, but they're afraid not to say, or they're afraid to say something wrong or offend me. So sometimes they don't say anything at all. Yeah. So all of a sudden, like there's this wall up between you, the patient, and like your little community that was never there before. And it's thank you for mentioning that, because that is very isolating. And that's why online communities have come in played such a huge role for me. And also the Dempsey Center, going to a place where other cancer patients gather.
Yeah. And listeners, Trevor actually is the founder and director of a nonprofit called Man Up to Cancer, which specifically helps men in the situation he found himself in. So we'll talk a little bit more later in the episode, I think, about your advocacy and about the organization, because we definitely want folks to know about it. But I'm curious what Dr. Evans remembers from that earliest encounter with you. And
he probably remembers a hot mess.
Well, again, everyone who comes to that spot comes fearful, if not terrified. And, the head is spinning, trying to wrap their head around a diagnosis, trying to figure out what the right treatment options are, who to talk to, what the conversation should be. Everyone's in that moment, and that's something we're used to. I think just personally as a physician, Trevor has always resonated for very obvious reasons. We're similar in age. We live, a mile apart? And amazingly enough, we both have daughters named Sage.
that is kind of a wild coincidence, yeah.
Which is wild, right? So it's not hard for me, it never has been hard for me to put myself in his shoes. And to some degree as a physician, that's a place you want to be, but it's also a very emotionally difficult place to be. You want to be there because that's how we expect our physicians to act, right? You want a physician who's going to tell you what they would do in the end, right? Yeah. That's what we all want.
I'm sure people ask you that all the time. If you were in my shoes,
what would I do?
Yeah.
And that's always been easy because of the similarities there.
Yeah.
Yeah, I get emotional about it because, remembering that time and how hard that is. And I think when people think about a medical oncologist, they think about the biology and the science and treating the disease, which is all true. But there's a huge emotional aspect to this. So Dr. Evans is holding the emotions of me and my wife and our kids, and the whole practice, right? The nurses, the PAs, everyone over there, they're not just treating your cancer. You come in there with a lot of emotions and feelings. And I get emotional now just thinking about that first, because that first entry point, when you're first getting your chemo and you're first getting your surgery and all that stuff, the emotions are so raw and they're so upfront that you can't hide them if you wanted to.
Yeah. And you do have to hold a lot as the doctor. I was wondering if there's anything, kind of a practice that you have or a personal philosophy or a series of things that help you, because you're a person, you go home to your kids and family at the end of the day. And certainly you've lost patients who you've been close to over the years and so on. Is there a practice that you have that helps you look after yourself emotionally?
I think what's always been important to me is to make sure that I am staying within the moment. And for me, that means when I'm with a patient, my attention is on them. So the exam room, particularly with modern healthcare, feels like a very sacred place, and that is one spot where I get to be one-on-one with a patient, with a family that doesn't have the phone ringing and pagers going off and kids texting, that kind of thing. That can just be one spot where my attention is completely focused on one person. And then, move on to the next, but focus on getting that interaction correct. To some degree, the science and treatment algorithms are almost the easy part, right? There are textbooks and algorithms, and we partner with Dana-Farber and have Dana-Farber pathways for all that. But it's the art is in translating that into something that a patient can understand and get behind, and fits with their lives and goals, because everyone's different.
That's very true, yeah. I've heard you say, so we know that Trevor mentioned he was 41 when he got his diagnosis, and I've heard you say this month, I'm learning a lot about colorectal cancer this month, a lot.
Good.
It's great, it is good. I actually had a beloved relative who we lost in the late 90s to colorectal cancer, and there was absolutely nothing like the awareness and the treatment that we have now, even then, which was not all that long ago, 26-ish years. But I've heard you say that colorectal cancer is the leading cancer death for people under the age of 50. Is that right?
Correct. That statistic came about this year.
That is...
It's a shocking statistic.
Yeah.
And it recognizes, unfortunately, that more colorectal cancer is being diagnosed at younger ages.
Yeah.
And that's the other important theme that Trevor hit on that I think is, as he pointed out eloquently, is very difficult for men in particular. The idea that it's okay to seek medical help if you're feeling poorly, and the importance of doing that at an early time point. And sure, there has been recognition that colorectal cancer is happening in younger age groups, and the screening age has decreased to 45. Trevor was diagnosed at 41. He didn't have the opportunity to be screened.
Right.
It wasn't a failure on that end. It was really just reflective of it can happen at a younger age than what we think.
Certainly, yeah. So you have always worked in cancer care, but I know you're not, a researcher per se. You're not in there with petri dishes and so on, kind of. But what is your gut, no pun intended, but what does your gut tell you about like why these incidences are increasing among younger people?
That is the $1 million question right
Yeah.
now, but you weren't far off the mark with your gut comment. Certainly there are a percentage of patients in whom it is part of an inheritable cancer syndrome, but that's still the minority of patients under the age of 50
Right.
will ultimately be found to have an inheritable cancer syndrome. So what we're left with otherwise is the amalgam of what we eat, how we eat it, when we eat it, what our gut microbiome is, how we treat our bodies otherwise, how much exercise do we get, are we maintaining a healthy body weight? All of these factors play in such complex ways that there is never going to be one answer to that question.
Yeah. It's a complex picture.
Yeah, I agree. I mean, I think there's not enough work being put into answering that question in my mind, that upstream question. But you're seeing an increase in that young onset CRC in other spots around the world as well. But I think certainly diet, processed foods, but then other exposures, right? We're exposed to a lot more toxic chemicals than we are now than the generation before. So the stat that I always look at is a person born in 1990 has twice the risk for colon cancer and 4 times the risk for rectal cancer than a person born in 1950. That's a U.S. stat. So what's different, right, about the people, that person born in 1990? And it is a lot. So I think it is an amalgam. I think it's maybe a lot of factors. But I would say this is that the old stereotype that CRC, that colorectal cancer is for people who didn't take care of themselves, didn't eat right, or didn't, or older, or smoking or drinking and all this other stuff. Like, there's thousands of younger CRC patients getting diagnosed just by having the typical American, right? Like, there isn't any like huge red flags for a lot of these people about like, oh, they're eating 5 times the processed foods. They're just eating what's available to them in our culture.
Right.
So I want to try to take away like the guilt or shame,
The stigma.
Yes, the stigma around this diagnosis, because there's like I always joke, like there's people who grow up in Vermont like eating birch bark and like maple syrup, and they're getting colon cancer.
Yeah.
And yes, we need to think about lifestyle. People should be, right? People should be thinking about processed foods and toxins and things that go into their body. Absolutely. But also we need to be thinking about, why is this disease happening in people for whom those red flags are not present?
Sure. And do you consider that before your diagnosis, were you pretty healthy as far as you were concerned? Or what was your lifestyle like?
Yeah, I mean, pretty typically, maybe I had a couple pounds, I had a bourbon here and there. I had a history of processed foods like every single person I grew up with. But for me, I did have that germline mutation that I had inheritable, right? I had an inheritable trait. So I have Lynch syndrome, which is basically where one of the genes in my body that's supposed to spell check for errors doesn't function. So cancer can develop from that. So there is a piece of my diagnosis that is along those lines of inheriting something, but also something did trigger it.
Sure.
We don't really know what that is.
Yeah.
But I have experienced, I have so many friends, hundreds of friends around the country who are living with CRC or who've passed away from CRC, who are just typical younger Americans. And man, we need to put more resources into figuring out why this is happening so that Dr. Evans can see less of these patients coming in with and presenting at stage 4.
Yeah.
Because that's the other thing to talk about is colorectal cancer. When you're diagnosed at stage 1 through 3, you're looking at very favorable outcomes in general. But at stage 4, the odds of surviving 5 years is still less than 15% at stage 4, which is a really tough diagnosis. And we have limited therapeutic tools to address that.
That's a very tough stat. Yeah. Dr. Evans, let's talk a little bit about the kind of the awareness piece / prevention, because that's definitely a big focus of ours this month. And you mentioned that your only clue was this fatigue that you experienced. Is that something that you see from a lot of colorectal patients? I know there's a lot of other things that people need to be aware of as far as signs, but is extreme fatigue something that
So it
often
certainly
presents?
can be. This gets perhaps a little bit technical, but Trevor's tumor was in the ascending colon, the right side, and that's often how those cancers present with, they bleed a little bit very slowly, not enough to really catch your attention, but over time it causes anemia. So that is one way that this is diagnosed. Other things can be change in bowel habits, actually seeing blood in the stool, stomach pain, cramping, things like that.
Bloating, I think I heard you
Bloating as
mention
well.
bloating.
Yeah.
Yeah. So it just really kind of anything new and weird in the digestive area, you're going to want to get that. You're going to want to go
Correct.
to your PCP and kind of get that
Correct.
looked at.
And just to again build on one of Trevor's point, that idea of blame in terms of, I did something wrong and that's what's caused my cancer. I can tell you almost never do I see someone where I can hear their story with colorectal cancer and say, oh yes, it's because you didn't have enough blueberries, or there was the one extra Big Mac that you had. That just doesn't happen. And this can happen across the spectrum of lifestyle choices. Have I seen a vegan marathon runner with colorectal cancer? Yep, absolutely.
Yeah.
So we can influence risk with lifestyle choices to some degree, but we're never going to eliminate the risk entirely.
Yeah, that makes sense.
I think part of the awareness is for clinicians as well, especially like primary care physicians, because oftentimes what I hear from my friends who've been diagnosed who are in that younger bracket, they've had bleeding for years. They've had blood in the toilet. They've had symptoms for years, and they keep going back to people and keep getting turned away by people who say you're too young for a CT, or you're too young for a colonoscopy, or it's probably this or probably that. Or some people have even been told it's their mental health, like they're just imagining it. So I think that awareness of for the clinicians to know like that this young onset group is rising, and to be, first of all, we have to have young people be aware to watch their symptoms and be aware of their bodies and go to the doctor. And then on the other side, you have to have doctors who realize that this can happen in younger people now.
Yeah.
You know, I talked to Dr. Marshall at Georgetown. He talked about in his practice 20 years ago, if he would have someone come in at 35, it would be like somewhat of a unicorn. And now it's, if not the majority, it's a really good section of his patients who are coming in who are younger than 45.
Yeah, and I, again, another shout out to Dr. Pelletier, who took your word and actually investigated it, as opposed to saying, well, why don't we just wait a few months and see if you feel better in the spring, that kind of thing, right?
Yeah.
Maybe it's just the winter weather and dark and cold.
Yeah. Do you think that in Trevor's case, the difference of a few months could have made a difference in his, in the fact
It's
that he was
always
able to-
hard to say, and that fits a little bit into that mode we want to get away from in terms of blaming not doing this or that soon enough. But months, years, they make a difference.
Yeah, early detection.
Early
is
detection
key.
is key.
So let's talk a little bit more about kind of something you have both alluded to already, which is men with cancer and kind of how their experiences really can differ, I think, particularly when we're talking about colorectal cancer. I get the sense that a lot of younger men in particular find the whole subject kind of embarrassing, awkward. It's just not something that they want to think about or talk about, and therefore it's not something that the screening, the prevention, kind of all of these pieces we're trying to encourage doesn't necessarily happen. Have you found that that's true at NECS?
I think in general, playing admittedly to stereotype, yes, men functionally are much less likely to talk about a diagnosis like this with their friends. It is often awkward with men, whether it be colorectal cancer or prostate cancer is the other one that obviously is a male cancer. And it's an easy comparison to the breast cancer world, where there is vast amounts of advocacy. There is communities that form all over the place in a way that it doesn't seem to be natural. And that's, I think we can all see that's one of the most amazing things that Trevor did, was to build a community of men who are going through the same thing.
Yeah, absolutely.
And I that's unique.
It's huge. Your advocacy is just so incredibly impressive and admirable. So you saw a hole, it sounds like, in the sort, I don't want to say the marketplace, but in the culture. There was this gap that you saw and identified. Men need more help with this. Men need more support. So was that kind of your thinking going into the founding of your nonprofit?
Yeah, absolutely. I mean, and I think Dr. Evans is spot on. I mean, I think men are far less likely in general to seek medical care when they're seeing symptoms. I've known a person personally who had a jaw ache, and I'm like, what's it been, a couple of weeks? They're like, oh, about a year. Well, why aren't you seeing anyone about it? Well, I just don't, it's probably going to be something bad and I can't afford it. And I'm really nervous that it's actually going to be something, serious. I'm like, well, wouldn't that be reason to, to go get the help? But there is a little bit of a disconnect. But I think in our culture, men generally are raised to handle challenges independently. You're supposed to just be able to deal with it. You're supposed to be invulnerable in a way, like, get up back on that horse and rub the dirt off and just keep riding. Like, there's that rugged individualism that is not inherently bad in my view when it comes to things like, I don't know, fixing something around the house. But when it comes to cancer, that rugged individualism can be really damaging for getting diagnosed. And then after you get diagnosed, for taking care of yourself and doing the things to give yourself the best chance at survival. So what I saw as the gap was, I struggled my first year mightily, and Dr. Evans and his whole team can attest to this, with mental health, anxiety, depression, health anxiety, clinically, and to the point where I was in a really dark place, and I isolated, kind of just went into my man cave and was like, I had this imagination, like all these other guys were just dealing with cancer so perfectly, and they were just flying through it, and they kept working, and they were, fundraising and being involved in all this stuff. And I was so depressed and anxious that I wasn't really leaving my home. And I felt shame around that. I'm like, oh my gosh, I got cancer and now I'm failing at responding to it. So finally, thanks to my amazing wife, Sarah, like, honestly, I got to the point where I was just like, I feel like I'm a burden on you and the girls. Like, I just want to go away.
Yeah.
And my wife was like, F that. You're not going
You're
anywhere.
not allowed.
You need help.
Yeah.
And that, again, is a pain point for a lot of men, like accepting help. But I did. So I accepted help through folks at New England Cancer, and also the Dempsey Center here in Maine was a huge resource for me. So I went and sought help, mental health help. And as I went to the Dempsey Center and then started engaging in online communities like Colontown and Fight CRC and Colorectal Cancer Alliance and these places, and started seeing patients like me in their younger years, raising children. And like, as I started engaging in these resources, especially at the Dempsey Center, engaging in therapy, like counseling, group counseling, all that stuff, every space that I went to get help was dominated by women. It was generally women who were giving the help, and it was generally women who were receiving the help. And that was the gap that I saw. I was like, if men like me aren't accessing these resources and this help, then they're not learning about, then they're not getting the best, putting themselves in the best position to stay on their treatment, to live. And so that was the genesis moment for Man Up to Cancer, where I said, like, I want to create a place where, because one of the biggest hurdles that I saw is that even in 2020 through 2026, when I'm doing this, a lot of men still don't want to be vulnerable in a co-ed environment.
Sure.
There's a lot of men who don't want to be in a place where they're being vulnerable or talking about their weaknesses or what they are going through in that space. So I wanted to create a guy-to-guy space where men going through cancer could get that social and emotional support. Other places are dealing with how to treat your disease. There's lots of places like that, but there's very few places that are supporting social and emotional or so well-being. And there's more science coming out all the time that show that participating in community actually improves quality of life during cancer and improves mortality outcomes. So it's not just like, hey, we know it's good for you to get out of your man cave and participate. It could actually save your life to do so.
It has some clinical results there.
Yes. So my message is, whether it's Man Up to Cancer or other communities, I encourage men to just get out of that isolation and participate in communities, and it's going to really pay off.
Thank you for listening to On the Subject of Cancer. This was part 1 of a 2-part episode. Check out part 2 to hear the rest of my conversation with Trevor Maxwell and Dr. Devon Evans. If you're listening and heard a piece of yourself in this conversation, we're glad you're here. Cancer can be isolating. Conversations like this one with Dr. Evans and Trevor remind us that even when the experiences are different, the feelings often aren't. If you have a question, a comment, or a topic you'd like us to cover, please send us a note to onthesubject@necs.com. This has been On the Subject of Cancer. To learn more and listen to additional episodes, visit newenglandcancerspecialist.com/podcasts. Find us wherever you listen to podcasts.